Good day, everyone. It's my great pleasure to have been invited to give this year in review for gynecologic cancer, specifically for ovarian cancer with research to practice. I'm Dr. Kathleen Moore. I'm the Associate Director of Clinical Research at the Stevenson Cancer Center in Oklahoma City, and I direct phase 1 clinical trials here, and I'm a G1 oncologist. There was a lot to talk about this year, so we're going to get started. The first thing I'm going to talk about is PARP inhibitors. PARP inhibitors aren't new, so I'm not going to belabor a lot of the old data, but we did have some new data presented this year, some good and some thought-provoking that I'll take you through. So the first thing I want to show you is just a summary slide, and this is these are the 5 kind of clinical trials that have been presented in frontline ovarian cancer with use of PARP inhibitors as maintenance therapy amongst patients who have completed frontline paclitaxel carboplatin and have either a complete or partial response. And so this is the subsets who are BRCA. Now I say that with the one exception, which is SOLO 1, which you see in the middle of your screen, which was only done in BRCA. The rest were all comers, and these are the BRCA subsets. So looking at the left-hand side of your screen in the kind of dark blue, this is the niraparib series of studies, PRIMA done in the US and Europe, and PRIME done in China. I'll come back to that. In the middle is olaparib, SOLO 1, as I mentioned, only in BRCA. PAOLA 1, done entirely ex-US. This was bevacizumab and olaparib versus bevacizumab. And then on the right-hand side, presented in 2022, was Athena mono. There's another Athena coming, Athena combo, but this is rucaparib, so in green, versus placebo. So a couple points to make here. One is that even though with SOLO 1, I'm talking about a study that was entirely BRCA and the rest are subsets, we've pulled out the BRCA. The hazard ratios demonstrating an unprecedented benefit with use of PARP inhibitor over placebo is incredibly consistent. So there's no way you could say, and I don't think anybody would at this point, that SOLO 1 was an outlier. Irrespective of kind of the clinical risk, SOLO 1 versus PRIMA, for example, kind of high clinical risk with PRIMA, a lot of stage 4 and neoadjuvant versus SOLO 1. And then Athena's kind of in the middle. Hazard ratios are very consistent, 0.3 to 0.4. So that translates to a 60 to 70% reduction in the hazard of progression or death with the use of a PARP inhibitor. And this really is the standard of care for women with BRCA-associated ovarian cancer, either germline or somatic, which is why testing for germline, and if germline is negative, testing for somatic really is the standard of care for high-grade serous and high-grade endometrioid tumors. Now, things to note that are specific in 2022, I mentioned Athena mono. This is the first time we've seen data in the frontline with rucaparib. Athena is a much bigger study. It's kind of 2 studies in one. One was showing rucaparib versus placebo was effective, and we've seen that here. The second, which is not yet reported out, is rucaparib versus rucaparib nivolumab, and that is pending. The other new data we saw earlier in 2022 on the lower left-hand side of your screen is the PRIME study. Now, I've called it niraparib, and it is niraparib, but it is manufactured in China, so it may be just a little bit different. And the homologous recombination deficiency test, which I'll show you in another slide, was also mirrored on the Myriad test, but is not exactly the same. So it's a little bit different, but I think you can still consider it a study of niraparib. But here I'm just showing you the BRCA data, which again, very consistent. And that's important to point out because everything else I'm showing you is predominantly US and Europe, and this is a study in China, really just showing, again, the consistency of benefit here. Now, even more important, this is what we saw in late 2022 at ESMO, is that we're starting to see long-term follow-up in the front line. This is really what we're all waiting for, is we are impacting PFS. It is unprecedented, but are we changing overall survival? And we think the answer is yes, although what was presented is not quite definitive, but it's pretty good signal. This is SOLO 1, overall survival at 7 years. We have not reached the pre-specified number of events to do the overall survival analysis, the final analysis. This is not the final. This is looking at it at 7 years, which was pre-specified. And what you can see here is a clinically meaningful benefit in overall survival. Again, this is only in BRCA-associated cancers with a hazard ratio of 0.55. Wow. And that even accounts for the appropriate 44% of patients who crossed over and got PARP later in their lines of therapy appropriately. But the message here is, number one, we are seeing a signal of OS. And number two is you can't catch people up by waiting to use PARP in a BRCA setting later. The best place to use a PARP is in the front line. You don't catch them up later, which was kind of a question when Solo 1 first came out, but I hope this puts that to rest. Frontline, frontline, frontline. Now, the other question is, is it just BRCA, or are we seeing a benefit outside of BRCA? And we did see some signal of this with Paula. This was also presented at ESMO. Again, not an event-driven analysis, but it was a pre-specified landmark analysis at 5 years. 3 years after the PFS endpoint was the statistical analysis plan, so that was at 5 years. You can see on the left, in the intention to treat arm, there was maybe a little bit of a difference, but really overall not statistically different for OS. But on the right-hand side, you see the homologous recombination deficient subset, inclusive of BRCA. So this includes BRCA, but also includes BRCA wild-type HRD. And you can see the difference in the number of patients who were alive at 5 years, 65.5% versus 48.4%. So that's a striking difference. I think we can say we definitely are seeing a signal here that we are improving overall survival with use of PARP, really in biomarker selected populations, and I do think that's true. But OS is one thing, and I love OS, don't get me wrong, but now I'm greedy. So OS is one thing, but am I curing more patients? We've never talked about that. Well, let's start talking about it. So here is the surrogate for cure, which is time to first subsequent therapy from Solo 1. Meaning, if you never got a subsequent therapy, meant you didn't recur, and therefore you can kind of say you're maybe cured. So that's what I'm showing you here. This was updated at ESMO. This is the placebo group at 7 years. So at 7 years, we have 20% of patients who are randomized to placebo who never recurred at 7 years. And so there is a group of patients who don't need PARP. And I wish I could tell you who they were, because I would love to just leave people alone. Less can be more. It's 20% in this population. They didn't need anything. But look what happens when we give PARP inhibitor to this population. At 7 years, we have 45% of women who have not recurred. And that slope is very horizontal. So the events are really coming slowly. So as we start to approach 9 years, 10 years, which is, when we might be able to really call cure, it's probably not going to be that much lower than 45%. So we really feel that we've cured women with this regimen. We can't call it yet, but we really do feel like this is cured for some women. And so it's very exciting. The flip side to that is 55% of women did recur. And so we're not done. We still have to do better. But for 45%, they've been off therapy for 5 years, not recurred, living your life. And that's really what we want for all of our patients, to not just be in this hamster wheel of forever treatments. So this is pretty exciting. And we do have an update on this same idea from Paula 1. This is an updated now. It's at 5 years. Now I'm going to go back one. So look at 5 years here. We were 51% versus 22%, olaparib versus placebo, all BRCA. So let's look at Paula HRD, inclusive of BRCA, but not entirely, 46% versus 20%. Very similar. And that slope starting to get horizontal. We're going to follow this for longer and see. But this is 3 years off assigned maintenance without recurrence in almost half of the patients with HRD positive tumors on Paula. And that's very exciting for them to be off therapy and hopefully having great quality of life. So this will get updated. But I think this just reinforces use of PARP or PARP plus bevacizumab in frontline, especially in BRCA, and in my opinion, HRD as well. Now, I mentioned that we had some new data in the last few years. or just some other things to mention. Prima did also report out prolonged progression-free survival. And so this is just one slideshow from Dr. Gonzalez's Martin presentation at ESMO. They have not shown OS data yet. We're anxiously awaiting that. And I'll remind you that Prima is an incredibly high risk population. So it's really hard to compare to Paula and Solo, but you can see in the intention to treat population, the rates of 1, 2, 3, and 4 year progression-free survival for ITT. This is a very different population, but we do hold with benefit even in the entire population with use of niraparib, which makes it a very reasonable option irrespective of biomarker. And similarly, here's Athena mono in the intention to treat population. Again, I will point out this is a clinically different risk group than Prima, so you can't compare them. It's kind of between Solo and Prima. They had more neoadjuvants, but not as many as Prima, and that's just reflected in what you see here. And this is a much less mature study. It's mature, but it's less follow-up than the others. So really, we're just at this 24-month benchmark, 45% disease-free versus 25.4%, which is certainly different, but will require additional follow-up. But I think the take home is these are all good medicines is what I would say to you. So just to look at, we talked about BRCA. I'm just showing you the same kind of figure for BRCA wild type, but homologous recombination deficient. So of course, Solo 1 drops off because they didn't have these patients. And you see Prima Prime on the left for niraparib, Paula and Athena, with hazard ratios that range from 0.43 to 0.66. So still very solid improvements in reducing the hazard of progression or death with use of a PARP inhibitor. And I showed you the long-term data for Paula. So I do really feel like for HRD positive BRCA wild type, PARP really is, it's a standard of care, but in my practice, it's the standard of care unless otherwise contraindicated. But this group is really our challenge. This is the group of tumors that are homologous recombination deficiency test negative or unknown. And it's plus minus as to the benefit of PARP. For Prima, we do see about a 30% reduction in the hazard of progression or death, which is reasonable. Paula, we saw no benefit of PARP bevacizumab over bevacizumab, active control. And Athena mono looked very similar to Prima. So there is some benefit there for patients who are in response, their tumors are in response to their frontline chemo. We do get some benefit. It's nowhere near the magnitude of biomarker positive, but it is clinically and statistically significant and is an option. But the bottom line is we need to figure out why these tumors aren't homologous recombination deficient and fix that, or come at it with other medicines so that really we can change the appearance of these progression-free survival curves. These are much more vertical than what I showed you here. Look at the difference. Here's homologous recombination test positive, here's negative. These tumors recur very quickly. Now, I will point out, again, this was presented at SGO in March, Prime in your lower left. This was done in China with a different assay. But here, the homologous recombination deficiency test negative tumors did really well with niraparib. So we don't understand this really. The manuscript will be coming out. I'm not saying it's not real, because there certainly are pharmacogenomic differences between China, Japan, Korea, where it's a much more pharmacogenomically homogeneous population than a European clinical trial or a US clinical trial. And the metabolism of drug may be different. The biomarker may be subtly different. We don't really understand why this is, but were I practicing in China, I would not need the biomarker test to tell me to use a PARP inhibitor, because clearly the benefit is there. And this was a well-done study. So that one is a little bit of an outlier that we're interested in thinking about more. For US populations, I think there's still clinical equipoise as to how best to treat maintenance in the homologous recombination deficiency test negative tumor. And this is really a place where clinical trials are key. So I've talked about this, and I talked about Paula, which is the bevacizumab PARP versus bevacizumab, which I get a lot of questions about this, especially for BRCA. Do I need to use bevacizumab, or can I just use a PARP? Do I need to use everything at once for BRCA wild type HRD? Does that make PARP work better versus PARP alone? What do we do? Well, the truthful answer is none of the trials answer that question. We, as you can see on the left-hand side of this figure, in Paula 1, because of when it was designed, it's a great study. Isabella Ricard, I'm a big fan. I think she would say she would design it differently today with a monotherapy PARP arm. We all would, but it doesn't have one. And in Solo, Prima, and Athena, there's no bevacizumab combination arm. And so we can't answer this question with clinical trials. Fortunately, there are 3 ongoing trials, and you see them listed here. Nirvana, AGO over 28, and MITO 25 are testing this question. So we will have prospective data at some point, a long time from now. But patients are in front of you today. You're going to go see them right now. So do we have any evidence to guide practice today? We do have a little bit from Paula, but also from Ovario. Ovario is a single-arm study. We do have to acknowledge that, but it's maintenance niraparib bevacizumab in a population that is more like Prima than not. So is a lot of patients with stage 4 and neoadjuvant tumors who received chemo plus bevacizumab and then went on to receive bevacizumab and niraparib for maintenance. And they did use the individualized starting dose for niraparib in this particular protocol. And you can see that in the schema here outlined on the left-hand side of this slide. Bevacizumab was for 15 months, which is the label for bevacizumab. And then niraparib was really until progression or 3 years. And the endpoint was progression-free survival at 18 months. This is a high-risk population. So they said, if we get to 18 months, that's kind of already 6 months beyond what you see the median progression-free survival for a very clinically high-risk population. That will give us a signal. And they certainly hit that. So this is Melissa Hardesty's, Dr. Hardesty's work, and she's out of Alaska. So you can see the summary of the results here on the right-hand side. And this paper actually has been published. You can pull it. But I think the key point is the PFS rate, which you can see. I like landmarks for single-arm studies better than medians. So you can see at 2 years, in a very high-risk population, you have about 60% of patients still progression-free. That's a nice signal. It's hard to make too much of it because it doesn't have a control arm, but that's a pretty nice signal. You really don't expect that otherwise. You see the median PFS in the upper right-hand side, and then on the bottom, you see by HRD status. It's a little hard to read, I bet, for you, but if you pull the paper, you can see it. But looking out to 24 months on the x-axis, the square is HRD test positive, and the triangle is HRD test negative. So HRD test positive, you're approaching 75% progression-free at 2 years with combination PARP-Bev. So I actually do like this combination, especially for BRCA wild type HRD. This gives us nice safety data for niraparib Bev. We have safety data for olaparib Bev. And so if you like to use bevacizumab in the front line, this gives you some data to counsel your patient if you want to layer on a PARP.
How do these data compare to the olaparib Bev arm of Paola?
Very similar. So if you compare, I should make a slide about that. If you compare landmarks at 2 years, and we can go back to that here, for HRD test positive, you're maybe 70 to 75% progression free. And if we go back to the Paola data here in the HRD test positive but BRCA wild type, and you look at that 24-month mark, you're about 60%. But there are BRCA patients on Ovario, so it's going to bump it up a little bit. So I think it's probably ballpark the same for both of them. Honestly, I don't think there's I don't look at those curves and see vast differences. I would right now consider them pretty much equivalent to one another, and just comes down to which PARP inhibitor a particular investigator is more comfortable using.
What about your question of, do you gain additional benefit from Bev over PARP by adding Bev in BRCA patients?
Clinical trial-wise, we just have to say we don't know the answer. We have not done the trial. We did do an exploratory analysis that's been published. Ignace Vierhote is the first author on that, and I'm on it, so you can PubMed me. I'm probably easier to spell. But we took the BRCA patients from Paula out, and then we matched them with patients from Solo who got olaparib who clinically looked like the Paula patients. So we did this propensity weighted matching to try and recreate the missing arm of Paula from the patients enrolled to Solo 1, like as if they might have been enrolled. And then we redid the progression-free survival analysis for that. And the hazard ratio did favor the combination with the hazard ratio 0.71, did cross 1, which you would expect for an exploratory analysis, but it looked maybe 29% better with bevacizumab. And if you recall, we didn't put this in this slideshow because it's a decade-old data, but that's what you get with bevacizumab. You get about a 30% reduction in the hazard of progression or death. So our take-home hypothesis for a BRCA population is that it's additive and not synergistic. So it's okay to do, if you're using bevacizumab, by all means, add on olaparib. But if you don't use bevacizumab, we don't feel like there's evidence that it's synergistic or curing more patients that you have to use it at this point. Now, in a homologous recombination deficiency test negative BRCA wild type tumor, I really want to see the results of those 3 studies that I pointed out. It's going to be a bit, but I'm very curious about that because we have seen data in the recurrent setting that targeting angiogenesis with anti-angiogenic agents plus PARP in a BRCA wild type tumor makes them look like a BRCA tumor. And we saw that with Joyce Liu's work with olaparib cediranib and Mansoor Mirza's work with niraparib bev versus niraparib. So if there is some synergy magic in that particular population, which is higher risk, maybe in a frontline you would see that, but we don't have any way of assessing that right now. And these studies that are ongoing will be quite important because if there's synergy, that would change a lot of people's behavior. You know, if you knew you were synergistic, you probably would start using more bevacizumab with PARP, with an intention to add PARP on in that group, than just leaving it up to sort of your normal practice pattern. But we don't have that data to answer it just yet.
All right, please continue.
Very well. So other things that came up in 2022 were frustrating and provocative, and we're still sort of chewing on this. But the audience should know there was an updated ASCO guideline that came out very late 2022 that was in follow-up to one that was done in 2020 when all the PARPs came out, and was updated initially in 2022, really just to include, the intent was to include the Athena data. That's why I'm on the review. That's why we called it. But while we were revising it, all of these Dear Doctor letters, HCP letters, healthcare provider letters, and retractions started to come out. And so we had to respond to that as well. And so what was happening and what continues to happen? Well, we saw overall survival data come out from these 2 studies you see listed here, Ariel 4 first, and then, or Solo 3 first, and then Ariel 4. These 2 studies were, for those of you that don't remember, the planned confirmatory trials for the original accelerated approvals for olaparib and rucaparib. So they were approved in 2014 and 2016, I think, as based on single agent data in BRCA-associated tumors with 3 or more lines of therapy. And then these were the confirmatory trials that were designed in the recurrent setting, BRCA-associated cancers only, PARP naive, PARP versus chemo. So Solo 3 was platinum sensitive, olaparib versus chemo. You had to have at least 2 lines of platinum before you could come on. So this was 3rd line and beyond. It's a very heavily pretreated population. And interestingly, they didn't have platinum as a selection. Ariel 4 allowed platinum sensitive and platinum resistant, and they had appropriate chemo to use for that arm, versus rucaparib. Again, all BRCA, all PARP naive. And the progression-free survival for both these studies was positive, as you would expect. Neither of these studies was powered for overall survival. And I'll talk about some of the questions we have about this. but they were made to present them, and there appeared to be a detriment. And you can see that here. This is the ITT population for areal 4. I'm going to show you another slide on this in a moment. But the blue line's the rucaparib, and the gray line is chemotherapy. So that confidence interval includes 1, but the hazard ratio is on the wrong side of 1. So 30% worse overall survival than with PARP than with chemo. And then solo 3, we saw the same thing, very consistent, 1.3 both of them. And so we had to update the guidelines, and you can see I edited it just for space, but you should pull the guidelines or wait, because we're going to have to update them again. So maybe wait. But really, we had to say that we don't recommend using PARP as treatment instead of chemotherapy in the recurrent setting for BRCA mutated tumors, or even HRD per the quadra that was retracted as well, that we can no longer support that approval. And in fact, that approval has been withdrawn. So this is really no longer something you should be considering, except in very rare circumstances, perhaps in a patient that's still BRCA PARP naive, BRCA mutated, and can't get a platinum. Then, of course, I would use a PARP, but it'd be a lot of conversation. But it's not a planned therapy anymore, based on this data. And this was presented in 2022. So very recent data, and the papers are coming out. Why are we questioning this? Because you might say, well, that's just what it is. Why are you mad about it, Dr. Moore? Well, these were never designed to look at OS. So let me show you just with one example why we think there's a problem. This is areal 4. I told you it's platinum sensitive, platinum resistant, partially platinum sensitive, which isn't really a thing, but it was in the study. Rucaparib versus either weekly paclitaxel if you're platinum resistant, or platinum-based chemo if you're platinum sensitive, until progression. There was optional crossover for the patients who received chemo to get rucaparib, one-sided crossover, not the other way around, which is important. I'll come back to that. And then follow up. So the optional crossover is key here. So here's the breakdown for OS across the three categories: platinum resistant, platinum sensitive, fully platinum sensitive. Partially platinum sensitive is 6 to 12 months. And then fully platinum sensitive greater than 12 months. Okay, here's the problem. For the intention to treat group for areal 4, 19% of the patients randomized to chemo initially received no further therapy. So once they progressed, they got nothing else. They went on hospice or died or something happened. Only 19%. But for the patients randomized to rucaparib, 42% got no further therapy, nothing, after that rucaparib. That's very different. Remember, platinum resistant or platinum sensitive, we keep going, treat things. So 19 versus 42, there's something going on there. So what happened? Let's look at it by arm. For platinum resistant, rucaparib, 42% got no further therapy. For the chemo arm, only 23% no further therapy. The chemo arm who did get chemo, over 90% of them crossed over to rucaparib because it was supplied. In the partially platinum sensitive, 38 versus 16% no further therapy. Of those in the chemotherapy arm who did get something, 96% got rucaparib because it was supplied. And the same thing here in fully platinum sensitive. Fully platinum sensitive. Rucaparib, 52% or 48% got no further therapy. Platinum sensitive. Why didn't they get another platinum? What happened here? Versus 15% for chemotherapy, and then of the chemotherapy arm, about 63% got rucaparib and the others got a platinum. So what happened here is that the study was done ex-US because rucaparib was approved, and you can never randomize it in a place where it's approved. And it was done in countries that don't have the same access to therapies as we do here, or maybe they do in France or Spain. And so for the patients who got randomized to rucaparib, which was supplied, they didn't have access to any other therapy. As opposed to the patients who got randomized to chemo, because in many of these countries, the companies are required to supply that chemo. And then the one-sided crossover to rucaparib, they got another line of therapy there. So you have completely unequal treatment post-progression that is going to impact your overall survival. So this isn't interpretable data. in my opinion, and makes it hard for me to like look at that ITT. And the same thing's true for Solo 3, by the way, and 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 be upset about it or not upset about it, because I don't feel like it's interpretable, because these studies weren't designed to look at OS. So that's just one reason statistically we wonder what happened here.
As a result of these and other data, rucaparib did not get approved in frontline therapy. So my question is, why didn't olaparib and niraparib get pulled off the market, if that's the
Well,
case?
now you may know something I don't. I don't think that the FDA has opined yet on the Athena approval. I don't think it was denied. I just don't think we know yet.
I thought they
Unless you know
said you have
something
to
better.
wait a couple. No, I thought
Yes, they
no
have to wait.
public knowledge. You have to wait. That's what I'm saying.
They have to
So
wait.
yeah,
Yeah,
I'm not saying they turned the approval down, but
correct.
they want to see more data, and they
They
don't
want
want
to
to
see more
see
data.
more data with olaparib and niraparib. So just I don't know.
Well, I would say that you're right. So they want, and this is going to be an ongoing requirement by the FDA. I think we'll see that with other studies. There's 3 other frontline studies, Duo, First, and Keylink, who've all finished accrual and are maturing, and we expected readouts this year at some point, and say they're positive PFS. We're all expecting that none of that will unfortunately translate into an approval, because the FDA is going to require some percentage of events for OS before they are comfortable with an approval. A lot of times we'll come in with a PFS, and maybe there's 20% maturity for OS, and you kind of just wait for it to read out. That's been my experience as an investigator for a long time. I do not think that is going to hold any longer. And so, unfortunately, I mean, this is just my opinion. This is all my opinion. I think that rucaparib just came in late and are suffering because of a change in sort of assessment.
Right,
So, right, we're
right.
going to have to wait for more OS to come out. Now, I don't think, again, I don't know a lot of insider things. I would be surprised if they're not looking at and waiting for the OS from Prima. They have the OS from olaparib, and that looks okay. And they have the OS now from Paula. We'll see what they think of that. I think it looks pretty convincing. And it is analyzed consistent with the statistical analysis plan that was put forth at the beginning of the study. So though I think, in my opinion, olaparib is probably safe in the front line, but we haven't seen the Prima OS data yet. And that I bet they're going to look at. And the challenge there that makes me a little worried is that population was very clinically high risk. Stage 4 and neoadjuvant partial responses, they were women with very advanced disease, very different than the other studies. So the OS may look different. Hopefully it looks different in the same way in both arms, but we're all a little bit on pins and needles to see that result. I don't think they're off the hook, unfortunately. So this is sort of one of the several sort of statistical reasons that we question the analysis of OS for some of these studies that were designed really long ago. But the flip side to that is, could it be true? That's the other thing we want to know. The statistics are true, and I do have a problem with the crossover, but could it be true? Because I don't want to harm patients any more than any of you do. And there is some biologic plausibility here. I think we just have to acknowledge that. And this was also presented last year as one of these things that evolves and we're thinking about. But this is one hypothesis for why this could be true, especially amongst BRCA-associated cancers. So this is data from Solo 3, which they wisely looked at reversion mutations. Again, these were patients who had received at least 2 lines of platinum when they came on Solo 3, but many of them had, like almost 40% had 4 or more lines of therapy. So you would consider them heavily pretreated, often with platinums, and still platinum sensitive. So they said, well, how many of them come on with a reversion mutation, and then how many develop it during exposure to either chemotherapy or PARP? And so this is interesting and a little bit scary for us, in that both arms had about 4%, 3 to 4% reversion mutations at the time they started Solo 3. So both on the olaparib arm and the chemo arm, very evenly distributed, kind of by accident, but fortunate that they saw a few reversion mutations. So these aren't super common. But on olaparib, you saw it develop 18% reversion mutations. And no additional reversion mutations were developed on the chemotherapy arm. I will remind you, they couldn't use platinum, though. So it was weekly paclitaxel, PLD, or topotecan, I believe, which I guess could cause a reversion, but probably not as much as platinum. So there was some difference there, but 18%. And if you develop a reversion mutation, you're not going to respond to PARP, and there is some overlap with response to platinum. So that could impact long-term how you respond to things potentially. And we're following this and learning this as we go. But that's plausible that could impact overall survival. So I think right now the message would be no longer recommended to use PARP for treatment, which honestly we shouldn't be. It's all frontline in biomarker positive patients. And reversion mutations happen either on or off PARP. PARPs aren't entirely responsible, but they do appear to play a role. And how we track for these reversions and what we do about them is ongoing intensive research by really, fortunately, brilliant scientists. So we will have more data on that coming forward. The sort of second line of or follow-up of data that came out in 2022, I talked to you about the monotherapy. All of those were monotherapy use of PARP versus chemotherapy. But what about combinations? There's so much work being done with combinations, either to make PARP inhibitors work better in tumors that are inherently homologous recombination proficient, or use them again in a tumor that's become resistant to PARP. Can you overcome that? And so there was some data presented and this is Mediola. This is probably the one we're most excited about, and I'll tell you why in a moment. But this is Dr. Susanna Banerjee's work. Mediola is platinum sensitive, BRCA wild type, PARP naive, and they took it's randomized, and they looked at a triplet of PARP inhibitor, immune checkpoint inhibitor, bevacizumab, so olaparib, durvalumab, bevacizumab, versus olaparib, durvalumab. So basically PARP IO without bev. And it's platinum sensitive. You can see the demographics here on the right-hand side. It's a very kind of standard population for a platinum sensitive study. And small, it's 30 patients per arm. So keep that in mind. But these are the results. And this is not new, but I'm just reminding you. This was presented a bit ago. These are the response rates. So the waterfall plots, you can see the triplet on the left and the doublet on the right. And I would want my patients on the left, on that triplet arm, where only 2 patients didn't benefit. Everybody else had some tumor reduction, if not a response. And even more impressively, if you look at the chart on the bottom, LOH positive is the homologous recombination deficiency. 100% response there, which you kind of would expect. But in the group that's homologous recombination test negative, 75% response. That's compared to 17% with PARP immune checkpoint inhibitor, which is what we've seen. I'll remind you, Topazio, Opal, every other study we've done is 17%. And this platinum sensitive is still 17%. So is there some magic with the triplet? That remains to be seen. But Dr. Banerjee updated the data at ESMO just a few months ago, and this is the median overall survival. Again, we're really starting to focus more on overall survival at 56 weeks. Triplet on the left, doublet on the right, and you can see the 2, and these are recurrent, so platinum sensitive, sometimes several lines of platinum. At 24 months, you had 65% of patients alive post-study versus 50% with the doublet. This is a little bit hard to interpret because it's small numbers. You expect, that's about what you expect in a platinum sensitive setting, that on average, about half of patients will be alive at 2 years, although we hope it's longer. So I think the thing here is that it doesn't look like we harmed patients with this. It's not incredibly short, but without a control arm, it's hard to know how to interpret this. But this is some updated data. But just the reason we're excited about this signal, especially here, is I mentioned earlier in our discussion, Dr. Lev, that We have four studies that are maturing in the front line. One that's, I mentioned, rucaparib versus rucaparib nivolumab. That's Athena combo. The other three are triplet. So first, Duo and Key-Link, they're all a little bit different. One requires bevacizumab, the other two allowed it. So it's about half patients had bevacizumab, immune checkpoint inhibitor PARP. So we're going to have three huge studies reading out with this triplet in the front line, which immune checkpoint inhibitors haven't worked yet for us. So this is like the final push. So if any one of these reads out positive, which I hope they do, because in full disclosure, I'm the USPI for first, it will bring immune checkpoint inhibitors into the foray for ovarian cancer. And if they work in homologous recombination test negative, per our conversation about potentially, are we going to be reassessing current approvals outside of biomarker positive, this could really throw a huge wrench into sort of what we're using in biomarker selected populations. So more to come on that. I think we'll see things read out in 2023. So when we do our year in review in 2024, we'll be able to have this conversation again. So I mentioned prior PARP inhibitors, and we did have an update on the OREO study at 2022. Just to remind you, OREO was presented in 2021. This is Dr. Pujal-Larraid's work, which asked the simple question, can you use a PARP for maintenance a second time, and will it work? Which is a very important question. This study was very well done and unfortunately does not answer the question we need it to now, because I'm showing you this. If you look at the patients who enrolled, I mean, look at this, like 50% or more had 4 or more lines of chemo. So they clearly got PARP inhibitor in the platinum sensitive recurrent setting. Those were the first approvals. So that makes sense, and progressed on a PARP. As opposed to starting at frontline and getting it for 2 years, and then maybe 2 years later they recurred and got it again. There's different ways we look at PARP duration now. So this is really a group of tumors that had been exposed to PARP until they grew, heavily pretreated. And I like to say it's the most negative positive study ever, because these are positive. The hazard ratios, these are non-proportional. So even though the medians are terrible and they don't differ, the area under the curve is significantly different. The hazard ratios are quite positive because it's not proportional. There is a subset who benefit, and you see them in the blue. But the majority of patients in either arm, they just progress the moment you stopped their platinum. And so this is, again, another call to action that we just need better, newer agents rather than reusing things. But the table at the bottom is the updated data that was presented at ASCO 2022, where they just looked at OREO and said, well, can we tell who would benefit from a second PARP? Is there anything we can glean from this to guide use? And really, they just identified things that we kind of all know are prognostic factors. And I'm not belittling this. It just didn't show us anything landmark that, if your CA125 is markedly elevated, or you have visceral disease like liver metastases, and then patients who'd received prior bevacizumab did not do as well. And I think we all know that. So it unfortunately doesn't tell us the group of patients for whom repeat PARP should be used. So this is a can do. You can do this. I've done this. I don't think it's wrong, but really I want new things to use here, so I'm not reusing old drugs. And so to that point, we'll talk about antibody drug conjugates next.
Just real quick question, real basic question. When I see a hazard rate that's below 1, like 0.43, like you just said, okay, I understand how to apply it. It's a 57% reduction. How do you use like a positive, like 1.82? What does that mean? Like how do you convert that the same way you convert the other way?
80%. So if it's 1.82, which I hope we never see, that's an 80% increase in the hazard of whatever your endpoint is. So if you're looking at PFS, that means you had an 80% worsening of progression-free survival with whatever you did as compared to your control arm. So it tells you if you're above 1 and statistically significant, sometimes you're above 1, but that confidence interval is huge. Like if it's 1.13, but it goes from 0.7 to 1.2, I don't know what to make of that. It just depends on where that point estimate falls. But if you're really over 1 and that confidence interval is all over 1, That's a sign of harm.
Well, how do you get 2.85 though?
Where do you see that?
Like what's that? Well, it's a part of the standard deviation of visceral disease, 2.85. So like, what does that mean?
Oh, so basically what that means. So this is saying if you have visceral disease, this is telling you how much worse you did based on
But I'm just
progression-free
saying,
survival.
but what I mean is, how do you convert that to a relative risk reduction? The way when you said 80%, like what percent is it with 2.85?
Oh, I mean, visceral disease, yes versus no. If you have visceral disease, it's 2.04 is your hazard ratio. So you have 2 times the likelihood or 200% likelihood of having progression as compared to not having visceral disease.
Okay, please continue.
So take homes from PARP, and then we're going to move to antibody drug conjugates, is one, the overall survival signals. We can't say final data for SOLO yet, but signals from SOLO 1 and PAOLA really do indicate that first line olaparib maintenance, because that's the data we have thus far. So I'm not trying to be a commercial. That's just the data we have thus far. Maintenance does, I think, enhance the potential for cure and certainly enhances length of progression-free survival. And HRD testing, I really do feel like it's going to become more essential because these patients, I think we really do want to get to PARP. Now, for some patients, they missed the opportunity to get PARP in the front line and they've recurred and they're very platinum sensitive and they recur to second line platinums. There is some question about use of PARP inhibitors in that setting as well. And in fact, I didn't have time to go into this, but the approval for niraparib in the platinum-sensitive recurrent maintenance setting was retracted for BRCA wild type because of overall survival data that's even more confounded than the Athena-4 data. So that's a challenge. It's still approved in olaparib and right now still approved for rucaparib. And in my opinion, in a patient who's biomarker positive, this is what I'm using and I don't want to harm people. But in that case, I really do think the overall survival data is flawed. So in a PARP naive, platinum sensitive, biomarker positive patient, I'm using a PARP for now. For BRCA wild type, I think we really need to develop some additional agents. I'm going to talk about those next. PARP for late line treatment, not maintenance. Treatment instead of chemo, we are no longer recommending. And I think I've covered that pretty well before. So antibody drug conjugates are really what's coming. And I keep saying, well, we need new things. Let's not reuse everything. Let's use new things, develop new drugs. Antibody drug conjugates are answering the call. We have 2. One that has FDA approval. So this is new. This is mirvetuximab soravtansine. This is an antibody drug conjugate targeting the transmembrane protein folate receptor alpha. And it is conjugated with a cleavable linker, DM4, which is a metazenoid, so a microtubule toxin. Lots of data, lots of work done with mirvetuximab over the years, culminating in 2 studies, one of which read out in 2022. This is SORAYA, led by my very good friend, Dr. Ursula Matulonis and Rob Coleman. The single-arm phase 3, bet you hadn't heard about that, of mirvetuximab in platinum-resistant ovarian cancer, 1 to 3 priors. Prior bevacizumab was mandatory because this was an accelerated approval intent study. And you can see the results below. The overall response rate in this population was 32%. Expected benchmarks are about 15%. And then we broke it down by subgroups into number of lines and prior exposure to PARP. And really everything is very consistent. This medicine works irrespective of prior lines of therapy. And then this is the duration of response. You can see the progression-free survival curve, but really duration of response is what I like to look at. It's almost 7 months, which in a platinum-resistant setting is quite nice and what we were looking for. This was done only in folate receptor alpha high, I should emphasize. It did lead to an accelerated approval in November of 2022. These are the treatment-related adverse events. This isn't new. We've published extensively on mirvetuximab, so I think the audience has probably heard about this ad nauseum, but just to reiterate, it's incredibly well-tolerated, no alopecia, far less neuropathy than weekly paclitaxel, almost negligible to no hematologic toxicity, but we do see some low-grade diarrhea, so you have to be prepared for that. And then about 50% of patients have grade 1 to 2 ocular toxicity, which is keratopathies predominantly. And the mitigation plan is well spelled out in the package insert. Every other cycle, ophthalmologic or optometrist exams are required for the first 8 cycles, just to ensure safety, and that is also in the package insert. But these ocular toxicities are very well mitigated by the strategies, lubricating eye drops and steroid eye drops, as has been outlined. And the confirmatory trial is Mirasol, which we expect to read out in 2023. So another thing to talk about at our 2024 year in review. Dr. David O'Malley presented at ESMO an update on Forward 2. That's mirvetuximab and bevacizumab. This is quite exciting data. I want this paper to be published so that we can hopefully get it on NCCN. You can see the response rate in the overall population is 44%, quite high. Folate receptor alpha, they allowed medium and high, but it works in both. But more interestingly is that this program allowed platinum sensitive or platinum resistant. Sometimes patients with platinum sensitive disease can't get platinum again. They have allergies or other things, or hematologic challenge, and you can use this medicine safely. And you can see this here, platinum free interval, platinum resistant on the left, platinum resistant on the right. I'm sorry, I had them flipped, but the response rates are quite high. So this is a very active combination option to use. Maybe instead of weekly paclitaxel, bevacizumab, and you kind of lose the hair loss and some of the neuropathy. So I'm very excited about this data that Dr. O'Malley presented and how we move it forward.
What's a phase 3 single-arm study?
So this is interesting. It's a phase 3 study because it was done with registration intent, and it's how the statistics were designed. So this wasn't a signal finding study like most accelerated approvals, are kind of a signal finding and it looks good, so they give you an approval and you do the confirmatory trial. Like this was, designed power analysis based on all of the prior data to really be a definitive study to look at ORR and duration of response. And so it got a phase 3 label. It doesn't change anything, but just the power and the statistics around it are much more precise than a phase 2.
It's interesting. I never
it's a little
heard
nuance
of
that people didn't pick up. I know none of us had. We thought it was a typo, but it's actually real.
So does that mean that it's not going to be an accelerated? It is an accelerated approval, right?
It is an accelerated approval still, yeah. It's just was a much more definitive power analysis to come in with. We've been working on mirvetuximab for a while, and Forward 1 was a disappointment. So it was designed to really be a definitive answer for accelerated approval. Mirasol will be the ultimate confirmatory trial, and we're waiting on that.
Please continue.
The other rising antibody-drug conjugate is upafitamab rilzodotin, which we call UpRi because it's hard to say. And this is targeting the sodium-gated phosphate transporter, which actually we've tried to target this before with lifastuzumab. For those of you that remember that looked quite good, but didn't quite kind of make it out of the gates. This is a different molecule. This is not lifastuzumab. Same target, but a very different structure, very different scaffold you can kind of see on this antibody-drug conjugate. So the drug-antibody ratio is high, much higher than other antibody-drug conjugates. And this scaffold allows the protein to fold normally and not get stuck in the kidney and lead to the toxicities that we see with other high DAR ADCs. So that's novel about it. And it's also novel in that it has this payload that is, it's a microtubule toxin, but it's this DOLA lock mechanism that controls the bystander effect. So you see some exit of the toxin into the surrounding tumor cells to kill them, which we want for bystander, but with a DAR of 10 or higher, you don't want all that getting out. And so it locks some of it into the cell, which prevents some bystander, but also locks it into the cell to hopefully kill the cell a little bit better. So this is an interesting molecule. It's a very different structure than a lot of the other ADCs that we have seen. And it's cruising through development. So this was data that was presented at SGO by Dr. Deborah Richardson, who happens to be my partner. This is the waterfall plot. And this is what you like to see as a clinician. The majority of patients are getting some tumor shrinkage. So you can see the partial response bar there, and it's a pretty nice percentage of patients who are responding, but 67% have some shrinkage, which is what you want to see clinically. When you're using something in the recurrent setting, this is clinical benefit. So I really like this waterfall plot, and that has led to a study called Uplift, which is the accelerated approval phase 2 of upafitamab in platinum-resistant ovarian cancer. It's very similar to SORAYA with an overall response rate endpoint. That study has completed accrual and is maturing, and I hope that we will see it this year. So that is exciting. The confirmatory trial for that is this one. This is Up Next, GOG 3049. This is actually led by Dr. Richardson. Platinum sensitive, where we need things. Platinum sensitive, you respond to platinum. Here, they are testing for sodium gated phosphate transporter expression. In Uplift, they allowed all comers. Here, they're testing for high, which is about 2/3 of high-grade serous. So it's not rare, but you have to be high. And then you respond to your platinum and randomize 2-to-1 to upafitamab or placebo. And this study is open and accruing right now. And so patients can just be started on whatever chemo that they want to be on, that the provider wants them to be on, and they can send tissue testing to see if they're positive. And if they're not, you can kind of do what you want. And if they are, then you can talk to them about this exciting clinical trial. So this is open and accruing, and we're excited about this.
Could you comment a little bit on tolerability issues with UPRI?
Early on, we did, in the phase 1, and this, in all fairness, compared to mirvetuximab, where we spent a lot of time kind of really working out the mitigation strategies. Upafitamab developed pretty quickly, and we went up pretty high on the dose. I think in retrospect, a little too quickly. I was involved in the phase 1. And so we did run into some toxicity issues with tolerability, a little bit of pneumonitis at high doses, which we're not seeing at our current recommended phase 2 dosing, because I think we have the dose right now, and some nausea, vomiting, and fatigue at high dose levels. So we were at 42, which was just too high. So the maintenance study is at 30 because you've responded. You don't need to crush somebody with high doses where you're trying to get tumor under to respond. You just need to maintain it, right? So we're using a dose that's very well tolerated, but very active too. This has a pretty wide therapeutic window. So in the maintenance study, we're using a dose that's effective, but not the same dose you would necessarily use in a platinum-resistant setting where you're trying to get something to shrink to help someone's symptoms improve. Here, we're just using it truly as a maintenance. I want to maintain the benefit of the platinum. So I really feel like with the amount of work that has been done by the study team with mitigation strategies and also dose optimization, which they took very seriously, we have a tolerable dose for both settings. But it's actually going to probably be an individualized dose selection based on sort of what clinically you need to achieve. If you want to maintain something, start low. If I've got to shrink someone's liver metastases or their ascites because they're really struggling, I'm going to start higher. And I am going to have the data to justify that.
Yeah, in the webinar, I'm going to ask you to elaborate a little bit more on what you were saying about the mechanism of this ADC, because I never heard that. That's really interesting. But, broadly, we talk about ADCs all the time in oncology, like many different cancers. And some of them, have specific issues like ophthalmic issues, not just MIRV, belantamab and myeloma, and for that matter, tisotumab, right, has eye issues. Yep. But there's another thing too, and the most I've heard this has been with TDXD, anti-HER, which has a big bystander effect also, where they talk about chemo side effects like nausea, vomiting, and even alopecia. Mm-hmm. Is that kind of what you're seeing here with UPRI, or what you saw when you had the higher dose?
A little bit. We're not seeing, fortunately, the alopecia, but we were seeing the nausea, vomiting, and fatigue. And we saw that, quite frankly, with mirvetuximab as well. When we ran Forward 1, in the phase 1 setting, for whatever reason, we just didn't pick up on the kind of infusion-related nausea. And so we came into Forward 1 without specified pre-medications. And we actually saw pretty decent levels of nausea associated with the infusion, so that in Soraya and Mirasol, we're pre-medicating now, just like for chemotherapy. And it mitigates it. It's done. So I think it's that sort of same thing that we're seeing with upafitamab as well, is that you just need appropriate pre-medication. We try to use, you don't want to throw a million things at patients, make them sleepy with the Benadryl and the steroids. Patients they hate the steroids, and we don't need it here, fortunately. But we try to use less. But for this drug, we just may need to pre-medicate like we do most things with antiemetics, so that patients can stay comfortable and have good quality of life and gain the benefit of the medication. So I think it is very similar. And it's the more we use them, the smarter we're getting about mitigation and quality of life.
Okay, please continue.
So really I think the conclusion there is antibody-drug conjugates there's a lot of things that are in development right now that we're excited about that are coming in phase 1, but things that are in phase 2 and phase 3, other than PARP inhibitors, are really these antibody-drug conjugates. And for ovarian cancer, these are very promising. We have a lot of tumor-associated antigens on ovarian cancer, folate receptor alpha, sodium-gated phosphate transporter. These are our two kind of front runners. But coming up close behind, we have cadherin 6. There's Dr. Erica Hamilton presented data on a novel agent, DS6000, at ASCO. That looks really quite intriguing. HER2 targeting. Who would have thought about that in ovarian cancer? It's not widespread, but again, you're looking for the needles in the haystack. So if you find HER2 low, just like breast cancer, we're going to see some data coming out on trastuzumab deruxtecan soon from the Destiny Pan tumor that has an ovarian cohort. That may move forward, and so that's a totally different payload and a totally different target. TROP2, ALPP, ALPP2. There's a number of these antibody-drug conjugates that are in development, different targets, different payloads, and patients may end up eligible for several of them with very differentiated safety profiles from traditional chemotherapy that gives us more power to individualize the right therapy for the right patient at the right time. So ADCs, I think, are really on the brink of transforming things for us in ovarian cancer and probably in endometrial as well, as Dr. Tewari may mention, and probably will be a big focus of our next year in review. And I think then people should just be excited about the quality of science that's coming behind that. We have engineered T cells, cellular therapies entering ovarian cancer treatment. Again, talk about a niche population and matching the right patient to the right treatment. But this could be, really transformative for our patients too, early on. But we're really pushing the envelope to try and get away from empiric treatment and really more towards individualizing what each tumor needs. And we're finally making some headway there for ovarian cancer. So it's pretty exciting.